So hello and welcome. We're excited to continue the human factors conversation, the COVID-19 revolution in telehealth, access, equity, and best practices as part of Techlandia Summit. This is a week-long virtual conference focused on delivering better community outcomes through improved infrastructure and quality of life, efficient service delivery, sustainable and equitable growth, and long-term resilience. I'm Riley O'Brien, Vice President of Events and Experiences, and I'll be coordinating the back end of this Zoom call, and I'm with Dr. Thomas Doherty, and he'll be the facilitator of the session. A couple of rules of engagement before we start. All participants have been muted. Please remain on mute unless a TAO staff member, that's myself, or Thomas call on you to talk. You are welcome to ask or respond to questions in the chat box, or you can send them directly to me via special events. And then we ask that you engage via the participant icon on your screen, which you can give a thumbs up or a yes or a no, or slow down a little bit. We ask, please engage with us on social media during this session. We're excited to share what's happening throughout the Techlandia Summit and to get participant takeaways from all of our events. This session is also being recorded and will be found on TAO's YouTube within 24 hours of this event. A huge thank you goes out to all of our investors in Techlandia Summit. We appreciate their sponsorship, and we're excited to explore more topics related to economic resiliency, future of work, human factors, and mobility throughout this week. And finally, it's my pleasure to introduce our panelists for this session, Ray Costantini, CEO and co-founder of Bright.md, and Jennifer Stoll, Executive Vice President of Government Relations and Public Affairs at OCHIN, and our moderator for today, Dr. Thomas Doherty. So take it away, Thomas.
Thanks a lot, Riley. And I just want to thank you very much for all your work. I know this is a huge week for you, and I really appreciate all the work you're doing behind the scenes as well. It's been great. This is a really great conference. I've been able to help put together and coordinate what we call that human factors track. And this is coming out of work we've done here, starting in Portland with the Global Cities Team Challenge and some of the Smart Cities work, really working on what we were calling a thriving communities initiative. You know, if we're going to have a so-called smart city, what does that really look like, and what does health and thriving look like in a smart city? And that started a couple of years ago at one of the earlier Tech Jam conferences here in Portland. And at our very first panel, we had a really vibrant session where we talked about the needs of elders. We talked about health and wellness across the lifespan. We talked about equity. We talked about connections with nature and the outdoors. So our human factors track really looks at a lot of these issues. And of course, this year, in this season, there's been a huge focus on justice and equity and diversity. And so there's been a lot of soul searching and consciousness raising, and that's really informed our talks as well. And so we've had sessions on, what we would call design and inclusive design, or even what people are calling liberatory design, and how to avoid biases in computer design and software. We've talked about economic resiliency and the changing nature of work, connecting people with the outdoors. We've talked about different apps that people are using to try to connect people and kind of bridge different divides in our society. We've talked about using data to reassess law enforcement budgets, and we've got into some of the challenges of just looking at all the data that we do have around the world. And we've talked about corporate social responsibility. We had a person speaking yesterday from Keen Shoes talking about how, as a company, that Keen has been addressing the COVID pandemic, both in terms of its employees and also in terms of its social responsibility and serving the public. And another huge strand in this season right now is just an explosion of the use of telehealth, telemedicine, teletherapy, basically doing healthcare and all kinds of health and wellness activities on an online format, much like we're doing today with Zoom. And both of our speakers, Jennifer and Ray, and I'm going to have you both say a little bit about your backgrounds when you talk, but both Jennifer and Ray have been, this has been their territory for some time, this idea of distance health. I try not to use the word virtual health in this regard, because what we're talking, this is a little pet peeve of mine, but we're talking in real time. Nothing about this is virtual. It is synchronous and through distance. But if we were bringing in augmented reality or some other kind of virtual things. There is potentially virtual stuff, but this is not virtual. This is actually real conversations facilitated by technology. But Jennifer and Ray have been working in this area for a long time, and I know they've probably seen many dams break here in the last few weeks about what's available and what people are willing to do. And I will just say for myself, as a clinical psychologist and someone who does practice and works with clients in the community, it's been amazing to see the changes in the counseling and the psychology community in the last few months, particularly in the month of March. I would say that there was more change in regard of telehealth in a week than I had seen in about a decade, in the sense that the entire field immediately went online. And all the clients and patients kind of came along. And I expected a lot of pushback from clients and patients, and I really didn't experience much. And so it's quite interesting. So I think the systems had been building, the comfort with these systems had been building over time, but it just needed this crisis to push us over. And then because of the crisis, a lot of the rules and regulations were changed to open the floodgates to using all kinds of platforms such as Zoom or FaceTime or all these other things. So it's been pretty amazing. And I don't think it's going to go back. I just don't see it going back. Clients and patients have been, conditioned to use this now. Obviously with the COVID pandemic, this is going to be a multi-month, multi-year process. There are people at high risk for infection. So there's going to be the need for these kind of services going forward. And there are a lot of other things I think I'd like to get to in our talk that people in the public might not realize. I know as a practitioner, what's been challenging with using telehealth is that we have a very fragmented healthcare system in the United States, with people having different insurances and all of these kinds of things. So every single insurance has a different take on telehealth. And when it comes down to the practitioner level, that means when the practitioner is actually billing for their services, they have to check with every single insurance provider. And they may work with as many as 20 or more or 50 insurance providers. And every insurance provider has their own codes, their own system, their own rules. So it's quite Byzantine. So it isn't quite as easy to do this as people think. And there's all kinds of other barriers that the public might not be aware of. So that's just as a start, just to get us into this stuff. And Jennifer and Ray are coming at this from different parts of the ecosystem here in telehealth. I'm wondering which, I was going to have both Jennifer and Ray speak individually for a while, but I'm wondering what order might make sense for you both, in the sense of do you want to start with Jennifer and some big picture governmental relations, public affairs, and then Ray get into his work and technology? Would that be a good start, or the other way around?
I know Jen, she's more entertaining than I am, so she should go first.
Okay.
Oh,
great. Why don't you lead us off, Jen, and I'll moderate. And Ray's being humble here, but I'm really interested in hearing from you, Ray. This is for our first time to connect. So, but Jennifer, why don't you go ahead and kind of pick up where I left off, and how's the world been for you in the last few months?
Sure. And for those that don't know me, I'm Jen Stoll. I lead government relations and public affairs for OCHIN. Not everybody knows who we are as an organization, so let me give you just my two-second spiel on who OCHIN is. So we're a Portland-based, but a national nonprofit health IT and research collaborative. And our mission is supporting underserved communities have access to best-in-class technologies and services so that they can stay robust, sustainable, and competitive. And my mission as leading the government affairs team is to try to take equity, digital equity, out of the conversation as much as possible. What's been stunning to me over the last 3 years of my work and working for OCHIN is how we set policies in healthcare that really drive unintended equity conversations and divides. And nothing is more evident than in the digital world, the divides and between big commercial systems and those that are in the safety net. So OCHIN, we touch about 500 different organizations across the country, predominantly FQHCs, RHCs, public health departments, corrections facilities, those that were just ground zero for COVID crisis. And we have been innovating rapidly to support our members, our partners, redefine healthcare post-COVID. It's been stunning. And it's also been interesting and learning more about the policies that we need to fix in order to have a more equitable society in the digital healthcare world. So with that, Thomas, I'll stop and I'll let Ray introduce himself and go from there.
Okay, great.
Well, with that, I think arguably the conversation we got in front of us is more interesting than I am, so I'll keep my intro relatively brief. But my background is as a physician, internal medicine training, worked at a large health system here on the West Coast, helping to build and lead their digital health services group before founding and leading Bright.md. And there are a number of themes that I heard in there that are really resonant to me and to us as a company. And I think there's also a point or two that I would push back on. I think an interesting one, Thomas, that you brought up that I'll flag for a little bit more future conversation. You mentioned specifically this idea of synchronicity. I will tell you, we've got a lot of data to be able to show that that's in fact not necessary. And in fact, taking a more nuanced approach, it's really what we found is that if you want to have sustainable, equitable, high value care, it's about getting the information from all of the sources and getting it to the people who need it, and doing that in the most efficient way possible. I'll tell a quick story. When I was at Providence, we launched their telestroke program. That's a place where video really matters. That needs to be high fidelity, rapid, visual assessment, and there really isn't a way to be able to do that without that kind of video-based connection. We had some of our cardiologists who were really excited about these exciting new robots that you could roll around the hospital, and they wanted to be able to launch that with another highly acute condition, which is a heart attack or an acute myocardial infarction. And with an AMI, they were like, we should be able to use these robots to be able to do heart attack management from a distance much better. And we had this really great conversation about it, which is, well, what do you need in order to be able to manage a heart attack? And the things that they needed an EKG. They needed a set of labs, troponins, to be able to test their enzymes that gets released during a heart attack. They might need an echocardiogram, which is an imaging study of the heart, none of which actually needed to be synchronous. And I think it is that question isn't what's the right tool to be able to connect people. The question is, how can we make care as streamlined and equitable and sustainable and accessible as possible for everyone involved? And that's really been our core focus, much more so even than delivering care at a distance. For me, telehealth is incredibly valuable, and whenever you can get care at a distance, we should, for many different reasons. But that's really just changing the context of healthcare, where it can happen. It's not changing the construct of it. Everything that had to happen in an in-person visit also needs to happen via video. The question is, how can we truly change the construct? How does healthcare happen? What can we do that foundationally makes it a better process for everyone involved? So a slight distinction, but I think really broadening that aperture a little bit, we found that approach has let us bring a lot more layers of value to the health systems and patients and providers that we're working with.
Yeah, and
that's great.
And what I would add, though, to that, Thomas, is that, there are varying levels of ability to innovate and having tolerance to innovate depending on reimbursement structures. And so, it's really important. And the lens in which I'm going to be talking about today is from those that they receive public funds or serving our most underserved communities. And the tolerance for innovation, they have to innovate, but it's harder for them than if you have larger margins. So, that's a lens in which I'm going to come at it things today, because if you can do it in our world, you can do it anywhere.
Mm-hmm.
Yeah. And I think that's a great point, Jen. Another great one for us to expand on a little bit, but it's this legislation always lags innovation by its nature. And I think we're in an environment now where we've got an opportunity to be able to push legislation and regulatory environment forward to help catch up with innovation and need out there. But I couldn't agree with you more. I think the tools are out there to be able to make care better and to improve on both the opportunity to bring in revenues that make these health systems sustainable, and also to reduce the cost to make it more accessible, more affordable, and even more profitable, even at lower revenue, lower top line revenue numbers. So I think that's all really interesting conversation.
Yeah, this is really great. I'm reminded of our talk the other day on data and policing, because people come into it with some kind of passionate, simple ideas about things they want to get done. And then they realize the question is just really much more nuanced and complicated in terms of data. In our talk, we looked at many, many different levels and kinds of data, how you're looking at measuring health and well-being, and whether you're thinking about the public or government agencies. And so I think, there is a sense of excitement that then turns into a bit of an overwhelm, like, oh, this is a bit complicated. And so we're at, this is where we get to that point where we have to be patient and kind of move into this. So I think we've got the client or patient experience, the person's just, impressions of this system and how it feels. And I'm attuned to that because of my psychology work. But then we've got the overall safety net, the social safety net, and regulation, and how we actually support this in our society. And then we actually have the practice of medicine and the practice of healthcare. And then again, we have the technology. So there's a number of levels there. So, say there's at least 4 levels. And I think the danger is we don't miss any. We try to hold these 4 balls in the air in our conversation. Because I do know if we miss the client, of our callers or of our people in our attendees, I think unless they're a practitioner, primary touch is going to be their own personal experience and how it affects their lives, their family. And so that's where they're going to be coming from. And they don't necessarily have the perspective of the technologist or the physician. Mm-hmm. So it's really fascinating. So trying to hold those balls and not drop this. I suppose we might, Jennifer, as you say, add an equity lens to this as well, because these services are not evenly distributed across society, right? So there's another level there too.
Well, and we set different policies depending on the payer, and the conversation couldn't be more evident than this week. We really applaud the governor for bringing the payers to the table and OHA to extend telehealth policy till the end of the year. But, there are very different policies that dictate what commercial payers can do versus Medicaid, which drive a lot of the ability to adopt new tools and technologies. And so, how do we take our, traditional fee-for-service, and this is really where the conversation was going, and what I'd like to talk about today is how we can use technology to innovate in payment. Ray was talking about delivery. The delivery that I'm thinking about is how do we change how we pay for healthcare, and what tools, how do we adopt different tools into the mix to be able to think about different constructs around payment. And the delivery of care will be adopted, but because we have had inequities in specifically telehealth policy, big systems have been able to adopt these changes and integrate and play with this tool. Think of it as a tool, virtual care. And I know you don't like the word, but that's what I use. And telehealth have had their tools that they've had the ability to play with because they've had margins in their closed systems. Well, COVID has blown the doors off of what we've known, especially for those that are serving underserved populations in health centers across the state. They all those restrictions have gone out the door. And so it's like, okay, the rules have changed, go. That's really hard. It's really, really hard to innovate. And the health centers across the state of Oregon and all across the nation really should be applauded. And it's amazing the rapid innovation that they've been able to execute in essentially 12 weeks. They've completely changed how they deliver healthcare. And it's stunning what they've been able to do. But as Ray mentioned earlier, policies haven't kept up with that. And we're even having conversations now on DC and in Salem, like, well, really, what's the value of, really? We've just changed how healthcare is delivered, and we're going backwards. And so this ebb and flow, healthcare is really complicated. It doesn't, payment is even harder when you're dealing with the money around it.
Yeah, can you just for our attendees just in general terms explain why it's important the governor's order today in terms of extending benefits? Because I think that gives us more time to work on this. But can you just in plain language explain what the significance of that is?
Yeah, so there is a couple of different emergency declarations that were delivered, and they have timelines. So in a nutshell, that's what it is. And so the timelines need to be extended. Otherwise, those availabilities of services might go away. And in the case of telehealth, she brought together the payers for a voluntary agreement to extend telehealth payment parity until the end of the year.
Payers being insurance companies.
Yeah, excuse me.
Yeah.
I should be more specific, not be so healthcare wonky. Sorry.
Yeah.
So she brought them all together, and they had an agreement, a verbal agreement, to be able to do this. Some advocates would ask that it should actually go to the end of July of next year, because it gives organizations more time to really learn and innovate from the COVID crisis. And additionally, they would advocate that we could have flare-ups at any time. And even though organizations are starting to bring patients back in clinic, being able to deliver the right care to the patient in the right setting is critical during COVID. And we won't be able to get through that hump until after we have a vaccine. But it's a beginning. The conversation will be taking place in the long session next year about virtual care and what it means and how do we pay for it long term.
Yeah.
One thing I'd add to that, Jen, I think the extension is great in the spectrum of things, but all those are still just bandages. I mean, I think you and I are pretty well aligned around this. Again, coming back to that idea that legislation always lags innovation, I think what I would put out there, without getting too, again, at the risk of getting wonky, because I think both you and I can probably we risk going over that line. I think there's some pretty foundational principles that I think about from a reimbursement standpoint. One of them is that clinicians deserve to be paid for the care that they deliver. And I think that that's a really important aspect. And we've put a lot of, honestly, unnecessarily complicated constraints around what it takes, what modalities, what location do you need to be in order for that care to be valuable enough in order to be reimbursable, in order to get paid for that care. And it really is, the arcanities of it are brutal and unnecessary, and really we need to, I think, a foundational agreement among everybody involved that clinicians deserve to be fairly compensated for care that's delivered, regardless of what modality it's in. I think that's really foundational. The second thing to me is that clinicians are the people who are in the best place, the best position to be making a decision about what tools are most appropriate for care delivery, given a patient's needs, the availability of resources, the environment and circumstances. There's nobody who's in a better position than the clinician to be able to make those decisions. And so to be taking it out of their hands, to me, feels foundationally confusing and fraught. And then the third piece, and I think this is a societal one that we have to be thinking about, is we have to also be thinking about how do we continue to put appropriate downward pressure on the total cost of care. Healthcare in the United States consumes 18% of our gross domestic product, of our GDP, of our economy. It makes up almost a fifth of our economy. That's much more than in other developed nations, and we're not getting the results that we need to from it, and it's growing at twice the rate of inflation. And so it's threading that needle of fair and appropriate compensation, empowering clinicians, and finding processes and tools and policies that help us continue to put that necessary downward pressure on that total cost of care that we as a society, in the end, all shoulder. So again, without getting into the details, I think those principles I've found to be a really helpful foundation to think about the policy work that we really have to do as an industry.
Yeah. Yeah. So just to keep us up to speed, so, you know, from Jennifer's side, the governor's order is really important. So my understanding of this, and I think for our general understanding, is that the reason why we're able to do any of this telehealth with COVID is because there's been an emergency declared. And during this state of emergency, it's a different rules of engagement. And so without that state of emergency, then everything will theoretically go back to the status quo. And so
without action,
correct. Yeah. So what's happening is and this is just how healthcare works in the United States, it's by the state and things like that. So in our state, and at least in the state of Oregon, you know, the governor has sort of, we've extended the states of emergency such that we're extending this special case with this innovative period of time. All right. That's a fair distinction. So that gives us some time to play with this. We have a really good question from Sonia Lewis in the audience here, which can bring us back to the client-patient experience. And I think I'd like both Ray and Jennifer to think about this. So how do you build self-efficacy among patients who have never used telehealth so that they have opportunities to practice? So practicing with this and have confidence in the behavior of moving from going to the doctor in person to being okay or even comfortable receiving online care. She says she's a care provider turned user experience advocate. And she's thinking about people who have significant challenges with online versus face-to-face services. So this gets into a number of things. This gets into personal preference. It gets into someone's familiarity with technology, their digital equity in the sense of their ability to have access to the internet or broadband or Wi-Fi or any of these things. I know, you know, their generation in the sense of how comfortable they are with technology. You know, their age, their education. There's a lot of factors at play with this one. But what do we think? Now I'll let you have Ray get a start on that. Like, what do you think about building self-efficacy, which is confidence, empowerment to use these services?
Yeah, I think it's a great question. It's one that we spend a lot of time thinking about. And in the end, I think there's a subtle distinction that I would share with Sonia specifically, which is I think if we build tools that require patients to practice in order to have confidence, we've built bad tools. I think that our job is to design tools that are as usable as possible, that meet patients where they're at, understanding their constraints and limitations. There's a product story that I like to tell inside of Bright.md. For those people who work in the kitchen, who like to home cooks, they probably know a product line called OXO, O-X-O. And it was actually an interesting product line. It's vegetable peelers and spoons, and it was actually designed first, and most people don't know this, but it was actually designed for people who struggled with rheumatoid arthritis. And for those who don't know what patients, the experience for patients who have rheumatoid arthritis, they can have crippling inflammation in the joints in their hands in particular, and they have difficulty doing anything with their hands. So the idea was, we're going to build kitchen products that meet the needs of patients with rheumatoid arthritis. By doing that, by designing towards the audience that had the most difficult time using a product, they built something that was absolutely delightful for everyone else. And I think that that's the right philosophy and the right approach to take for all products, whether they're physical or digital, is how do we make this usable for our most difficult audience in order to make it delightful for everyone else? And I think that's one of the challenges that we've seen around video, is that intrinsically it is both socially complex and technically difficult to be able to use. And we can keep working on how do we make that better, but there are other approaches that can make it much easier. I mean, if you think about it, pre-COVID in particular, where we're all kind of forced to be using it, but even now, I mean, think about how often you text versus how often you FaceTime. And both of those are built right into your phone if you use Apple products. I mean, they're about as usable as you can make them. They're a push button away. And your frequency of use around one is much, much higher than the other one, because easier. If you think about folks, so switching it over into the healthcare space in particular, you think about low-income, underserved populations. And when we're talking about that equitability and the sustainability of care, even if you offer video encounters to our Medicaid or our uninsured populations, there are often folks who actually have pay-per-meg data plans and don't have Wi-Fi in their homes. So, even if you offered video encounters to them at a zero cost, a zero price point to them, that's still $15 in data charges that they're often going to be unwilling to use. If you're in Eastern Oregon, you've got 3G cell signal, and video is simply not an option for you. And so being able to find tools that are more learnable, that are more usable, being able to design for those folks, that's the way I think to be able to improve that equitability, as well as making it a truly more delightful and ubiquitous tool set for everyone who doesn't struggle with some of those additional challenges that we could layer in there.
Yeah.
Jen, thoughts?
Yeah.
Yeah, so I'll take it in a slightly different direction in that, we haven't had a choice but to do virtual care during COVID, right? So, a lot of folks that had been reluctant have had an experience of virtual care, and what we're finding is a vast majority of the community actually enjoy the experience. But one of the key components of that for OCHIN and our health centers has been the ability to do telephonic visits. The old telephone is absolutely key to this. Up to 29% of the encounters, the visits that we are being paid for right now are telephonic, which is something that didn't occur until the COVID gave the opportunity. Again, they allowed for payment for telephonic visits, and it's really fascinating for us to see is outcomes, especially for behavioral health patients. Anecdotally, we're seeing a tremendous improvement in terms of patient no-show rates and satisfaction. So, and we're not saying, telehealth is, again, a one-size-fits-all piece. I think both you're hearing Ray and I talk about the right time and the right patient and the right situation for that patient, right? So, not every visit is a telehealth encounter, but not every visit needs to be a face-to-face encounter either. So, but we've just started playing with this new tool because we're just starting to be able to get paid for it. And we're just starting to be able to see how do we build workflows, which is basically how does the system work? When you walk in, we're so used to having a structure where we walk in and the first thing we do is see the receptionist and they check us in, and then we have an assistant that brings us back and does all the prep work before the doctor comes in. All of that needs to be innovated in a virtual space. And so again, we're just starting to understand, and we need time to really sink our teeth into it and say, especially in the primary care delivery system, which is what we focus on at OCHIN. I do want to touch on another different piece, Thomas, if you let me, and that's around digital equity. Ray talked about broadband. Without a doubt, that is the #1 issue that we're facing, not only in Oregon, but all across the country with health centers, is especially in underserved populations. It's really, we think everybody has an iPhone and everybody is walking around with, cellular connection and an unlimited data plan. That's not the case. And it's even more important to know that, and we've got to find ways to close those gaps, both in broadband and in being able to assist patients with the tools that they need to be able to participate. Otherwise, we'll continue to drive that equity gap between those that have and those that don't. And the other thing that we are really focused on, so it's the digital knowledge base and how to use systems. And again, a lot of folks will defer back to telephone because it's just easier for them, and they don't have to worry about setting up and getting booted off their Zoom call, or is Mike, how do I install things? And those are real issues. And then the last thing that we are also continuing with is language and translation services. There's 138 languages spoken in health centers that OCHIN supports across the nation, and most of our technology is for English speakers and for the Caucasian population. We've got to do better as technology leaders. We've got to be able to think about how do we bring in more culturally competent tools into the system and translate it in languages that are proficient for communities of color and then other populations. It's critical, and we have to do it. I challenge everyone on this call to find ways to be able to translate what is in a standard format into formats, which is the English language, but be able to bridge that for the entire nation.
Jen, you're only saying that to be nice to me because you know we already do that. That's nice of you. I appreciate it. I think there's some really important points. And then actually, Thomas, to bring this back to mental health as a specific example, I think there's some really fascinating data out there. Again, thinking about what are the right tools, the right modalities to be able to bring to bear. There's actually some great data to be able to show that patients are actually more comfortable and more honest in sharing information on mental health in particular in an asynchronous rather than a synchronous setting. It's hard to sit there. If I'm feeling depressed or I'm struggling with anxiety, it's hard to be able to sit there and stare at somebody on a video and to be able to talk about those symptoms and those conditions, whether we like it or not, which I think all of us don't, nobody likes this, but the fact is there continues to be this sense of social stigma around mental health. And I think that is a real, if we don't acknowledge that, then we can't do better with how we address it. And we found that same thing. We've seen an explosion of utilization in our mental health care modules, these asynchronous interviews to be able to gather that clinical information from patients and to actually drive diagnosis and treatment. We found that we can be more thorough. We found that patients see lower barriers to utilization. We've seen that because we can reduce the cost and make care more accessible, because we don't have to require Wi-Fi or high bandwidth 5G type cellular connections. It's actually available to a broader population of patients, because we can interview patients in native Spanish and then be able to provide that translation, real-time medically certified translation over to the clinicians. We're improving the accessibility of care. So these are all, again, just to put a finer, more specific point on some of those very real and accurate points that Jen's bringing up. I think it is our burden as an industry to acknowledge those barriers and, in fact, to even take action. There are tools out there that can address every one of those issues, and just to own it, the reimbursement piece is a critical aspect of it. Being able to make sure that clinicians are fairly compensated for the care that's delivered is arguably one of the biggest barriers that we face as an industry and as a nation to being able to bring those better tools to bear and to improve those processes. So to put a very fine point on it, we all need to be doing that work to help legislation catch up with these better ways to make care happen.
Yeah. So let's hold the point about legislation, and we'll come back to that because I think that's a call to action that we can get to in this talk. But I want to thank you, Ray, for this is kind of a primer on digital health and on so many levels. But just this point that you made about some clients or patients really actually prefer asynchronous, they prefer distance. That's something that people aren't aware of. I find, and I believe if we want to simplify it, among the public, there's a bimodal distance. Some people really like in person, and that's what their value is, right? They really, then that's not going to go away. People are wanting that connection. And I know as a psychologist, I had to, and psychologists as a group, and almost many healthcare providers, but particularly psychologists and counselors, they tend to like in person. That's why they become counselors in the first place, right? Very few do it to become telehealth counselors. That's not why they go to school for it. And so they tend to be biased and kind of prejudiced against these other modes. And so they need to be educated. And I know that was a wake-up call for me some years ago to realize, the research, because the conceit would be that, well, obviously telehealth is not as good as in person. that would be everyone's assumption, but it's not the case. Research shows that actually for a number of clients, telehealth is as good or better. I wish we had someone from the Veterans Administration with us, the VA, because the VA has been really innovative in using telehealth and distance among military veterans who might be unlikely to seek help, say for a mental disorder or for depression or mood because of the stigma that you mentioned, just cultural norms and things like that. And so,
Thomas,
yeah.
I might even take that one step further. I think it's an interesting thing for us as an industry. I think we do have a tendency to start with what we as clinicians would like to do.
Mm-hmm.
And while that's not an unimportant thing to consider, we are here to provide high quality care to our patients. And I think we're increasingly faced with a choice that we are not always conscious of. Are we going to recognize that patients are consumers and they have a choice? And if we don't meet them where their expectations are and help them access care in a way that meets their needs as healthcare consumers, they will go somewhere else. Walmart will be more than happy to deliver convenient, low-cost care to your patients as a provider. The question is, are you going to force your patients to make that choice, or are you going to bring tools to bear so that you can provide that trusted care and sustain that relationship with patients? One other way that I found that's really helpful to segment this is, we often think about people as being more or less comfortable with technology from kind of a classic psychographic or demographic segmentation. And I think there's some truth to that, but in healthcare in particular, I think that wildly misses the real mark, the exact same psychographic and demographic segmentation. So you take you go for a simple segment here. This is not intended to point towards the equitability piece, but a college-educated, middle-income, tech-savvy mother of 3 who's moving around quickly and needs to get to 17 more things today. When she's got her 3rd bladder infection of the year, her comfort level with technology is radically different. Her desire to be able to access care conveniently and quickly is radically different than if she just found out that she's got a lump in her breast and is concerned about breast cancer. One of those needs a relationship. One of those needs a conversation and needs more human interaction. The other one, we should be able to find better ways to be able to rationalize how that care happens. We should be able to streamline that care. As a clinician, for me, one of the fascinating things is, what do we sell as clinicians? And I'm not gonna go into mental health because I think this is a little more nuanced, but in a general primary care setting, we sell 20-minute increments of our time, about 3 or 4 of which is actually spent with the patient. But we're selling 20-minute increments of our time. And if you come in with a cold, we sell you 20 minutes of our time. If you come in with diabetes, congestive heart failure, COPD, a foot ulcer, and a whole bunch of social determinants issues, we sell you about 20 minutes of our time. And that is a broken model from my perspective. And what we should be doing is saying, how can we deliver this care for patients who want that care in a more accessible, more convenient, more digital way when it's appropriate, so that we can then even free up that time for every patient who you take care of their cold in 2 minutes, and you do that remotely with care coordination tools and remote care services. That means we've now got 35 minutes to be able to spend with that more complex patient. We've dehumanized the in-person interaction in most care settings because we're so rushed. Providers need to see 20+ patients a day. The idea that is better than rationalizing that and being able to really put our time and our energy and our attention as clinicians towards the patients who need it more, I have a tough time painting with that broad of a brush. I'm interested in thoughts about that.
Yeah, no, I completely agree with what you're saying, right? But I mean, it's really interesting. Right before I jumped on this call, I was talking to a large federal agency about how do you measure quality of encounters. And what I find interesting is the extreme scrutiny that's going on around a care delivery method versus, there's the scrutiny around in-person visits. It's the microcosm of digging in so deep around, well, we have to prove that it works, right? And we have to we know it works, but now we have to prove it. And we could, I think that's part of the policy problem, is that policy isn't keeping up, and now we have to justify the need for it after we've opened it up clearly because it was the only way in which care could be delivered during the last 15 weeks or so. And
necessity breeds innovation, or at least
Totally.
Willingness to move forward.
But now we've got to have the metrics that keep up with it. We need the research to go along with it, and to measure it. But it's hard because the last few months have been such a crazy anomaly in healthcare delivery that that's not a good evidence base to really determine, was telehealth an effective tool? Again, we need time to really understand and keep these policies in place that we've opened up, and really lean into them to understand how they all fit into the larger conversation around healthcare delivery and cost. And we've got to study them and we need metrics around it. Sorry. I
think that's a place where you and I should keep collaborating, because we've got that data and we've got it in a remarkably structured and nuanced way. I think Thomas, I think I'm seeing a question coming that might be related to this, but like we're actually seeing really granular data about this. So examples of this. So again, I don't want to turn this into a plug for Smart Exam, but because I'm most familiar with the data around this, I'll talk about it a little bit. We're actually seeing that in-person visits, typically the clinicians will ask about 10 to 12 questions. And that's actually peer-reviewed published data out there. That is the typical interview length in an in-person primary care type setting. We know that with our platform, we're actually asking an average of about 35 questions, ranging from about 25 to 85 as kind of your spread. So we're actually able to be more thorough because we're not rushed. We can parallel process tens of thousands of patients to be able to gather that information in a really nuanced way. We never forget to ask key questions. So, your patient comes in with a headache, you could forget to check for nuchal rigidity because you're just not thinking about it because you're human. I forgot my cup of coffee. I've seen 3 other headaches today and I just didn't think about it. Part of the beauty of using technology to help coordinate that care process is that we never forget. We always know that this piece means that these things should be considered. We're actually seeing there's peer-reviewed data out there that shows that in-person care shows about a 65% adherence to evidence-based best practices and clinical guidelines. Video-based care, actually across the board, this was peer-reviewed and published, I think it was in the Lancet, but I'd have to go back and check on it. But they showed that it was about a 45% adherence rate to evidence-based best practices and clinical guidelines. We're actually seeing in our platform a near 90% adherence rate to those same evidence-based best practices and clinical guidelines. So there definitely is data that shows, so if you think about this from a quadruple aim standpoint, those are really good measures of clinical outcomes, which is a key piece around that quality metric. We're seeing, we had one of our health system partners with a 97% non-antibiotic adherence rate. So patients didn't, when it was not appropriate for a patient to have antibiotics, 97% of the time they did not. That is a stunningly high metric from a clinical outcomes. That is a hard outcome measure. We are seeing patient and provider satisfaction scores in the high 90s. We're seeing net promoter scores in the high 60s and low 70s on the patient and provider side. So again, thinking about this not just as a triple aim, but a quadruple aim around patient and provider experience. And we're seeing a reduction in cost per visit that is 10 to 15 times less expensive to be able to deliver care via a care automation asynchronous type modality than an in-person setting. So I think there absolutely is data out there, and we need to be able to take that data and bring it to bear to drive those legislative changes and help that catch up so that we can make it more accessible to these people who don't have access to care, who can't afford care, who don't have the broadband capabilities to be able to do that.
Mm-hmm. Yeah, this is great. So I'm going to time check. We have a breakout at 11, and we can just flow into that. But for folks that are going to be leaving at 11, I just want to tie some things up. So what you're talking about, Ray, is really user experience, but also like Steve's question in our chat, you know, online versus and phone versus in person might create a different outcome in terms of what information is gathered. So I think what I'm hearing really is an augmented, kind of you know, in broad technological terms, we talk about, you know, can computers do something? Can humans do something? Or can we have, you know, enhanced? Can computers enhance the human performance? You know, so it's not that we're outsourcing these things. We're actually, you know, the technology, the data is allowing us to do much more as a human. And so I think that's where you're getting at as a practitioner, because it is the case that an automated program is going to hit on everything you program it to do. A human will miss certain questions at any given time. They're just human, they're fallible. So there is the case for that automation. Can we use it to enhance the experience?
Well, and I think that's key. To me, what we often say is that until we're ready to be able to put software up to be board certified, we should not in any way be trying to position any software to be a substitute for clinician judgment. And again, as a clinician, I'll say that with high confidence. I'll say it twice. We should not have software that is positioned as a substitute for clinician judgment. What we've found is that using tools to act as a supplement to the clinician workflow, things like conversational AI and clinical decision support and good UI design to be able to make the clinician workflow. I mean, for God's sake, it takes 100 clicks to be able to deliver care inside of an EMR system. On average, it is 100 clicks. Can you think of the last application you needed to use to click 100 times to do one transaction? That's appalling. And so building tools that really supplement that clinician workflow, make it better, but empower them to make those choices, give them information, have them spend less time gathering the information that they know that they needed before they even walked into the patient's room. As a doc, you know half of the questions you needed to ask based on the patient's chief complaint before you even walked in the room, but you spend a tremendous amount of time gathering that information and even more time documenting it. How do we make that better? This is not a substitute for clinician judgment. It is a supplement for clinician workflows. And that's much, much broader than what I'll say is just telehealth.
Yeah. So there is a quality piece that will ideally translate out to the client and patient experience. But, you know, coming back to Jennifer, and we have folks from all around the country on our call. You know, I know we have a bunch of folks, you know, from Washington, D.C. in our group. And, you know, so at each state, what should people be advocating for at a state level around this? I mean, every state's different, obviously, but what broadly should what advice would you give the American citizen about what should they be advocating for with their elected officials regarding this? And that's a big question, but
it is around virtual care. I think you stated it from the beginning. We can't go back, and that's exactly what what we would suggest that you advocate for is there were all of these, for a lack of a better technical term, weird restrictions on who could do telehealth, how it could be delivered, where it could be delivered, what zip code you're in, I mean, all sorts of weird restrictions that really handcuffed providers on being able to reach their patients, either within the state or across state lines. You know, that's the number one piece, right, of what cannot be, we can't go backwards on. We have to keep the flexibilities that were given need to be retained and opened up during the emergency declaration given and the authority given from Congress to Alex Azar in the HHS and then also pushed down to the states around Medicaid flexibility and then encouraged by the states to the commercial carriers. So all of that kind of flows downhill. But the number one piece that I would say is all of those restrictions have to continue, just go away, right? You know, there is some controversy around the use of non-HIPAA compliant tools. That's a controversial one. And the other one is, well, I'm in Oregon, should a Texas provider be able to deliver care to me? That's also, you know, controversial on a local or more local level. But in terms of all of those other restrictions, they've got to go. And then we've got to figure out what to pay, how to pay for these services. We are advocating for payment parity because we need time to understand and innovate. Again, you know, because they just removed the handcuffs, now we can actually see what telehealth is going to be going to do. I mean, I had a conversation with one of our health centers who have been thinking about building a brand new facility, and they're actually pausing that build because they're saying, okay, how can telehealth, what do I need you in my location space, right? But we need time to understand it, especially in the primary care delivery setting. So I would say, you know, in terms of virtual care, it needs to be, keep the handcuffs off, and, you know, we've got to pay for what we value. The other thing that we're absolutely involved in is infrastructure build around broadband. We can't do business the way that we've been doing. The COVID has just blown the gaps off of blown everything up in terms of we have huge broadband disparities across the country. We've got to fix it. And luckily that is a funding issue more than anything else. So to continue to advocate for more funds for broadband expansion and build. And also that is a place, an area that is also ripe for innovation. You know, it's not just fixed wireless or fiber in the ground. It's going to take an and innovation in that space, whether it's, you know, TV white space, or whether it's, you know, satellite or other services to connect that last mile, because it's just not, it's not a cost-effective thing for the private sector to do unless there's incentives or policies in place that help close that last mile. So we have to be very thoughtful about broadband policy as well.
Yeah.
So I would agree with many of those things. I would say I tend to be a lumper rather than a splitter, and like I like frameworks. And so for me, I see three key pieces that need to come from this. So we need simplification, and I think Jen and I are very aligned around this. The arcanities and the complexity that are in there are disempowering, and in fact, they get in the way of care delivery. So I think simplification of those telehealth policies is really key. Second piece is empowerment, which comes back to that same idea of putting the clinicians in a position of being able to make those decisions about what are the right tools to be able to deliver care, given the patient's needs and the complexities of care in a given situation. And the third one is accountability. And the good news is we have a lot of tools already in place around this. Clinicians need to continue to be held accountable to deliver high quality care, then maintaining those standards of care. We have great policies in place around that across the country at medical board level. So while that's an important piece to maintain, I don't think there's as much work to be done there. But we need to know that that's there in order to simplify and empower. And then the last thing I'll say, Jen, I agree with you that the importance around broadband and infrastructure as a society. I mean, we're arguably being leapfrogged because we have got so much cable in the ground by developing nations who have gone straight to cellular, which is less expensive. And that's a whole long conversation to be able to have probably over a glass of wine instead of over a Zoom meeting. But the other thing I would say is we can't wait, because infrastructure, while it is funding that has kept us from being able to do that, that is a slow process. If we magically dropped all of the funding that we needed onto that problem yesterday, it's years before that's an answer. And there are better ways to be able to meet those needs even without the infrastructure in place. And if we wait on the infrastructure, then we are just putting a bandage on the problem and not using the tools that are out there that can actually help address it substantially, even in the near term, while we're putting that infrastructure in place, which is key in a broader societal need.
Indeed. Well, we're at our 11 o'clock, so I'm going to sequence more to the breakout. And, you know, we've got a lot of balls in the air here. This idea of broadband, I know personally in my work in the last few years with the Tech Association, I've really been educated about this idea of broadband and this whole split. I didn't quite realize the nature of this infrastructure. A lot of people don't. So that's something maybe to talk about more. I'm wondering about the experience of different demographic groups, African Americans, elders, rural. There's different diversities here that we can talk about. So I know Steve put a nice message in to the chat, which is a good wrap up for this section of our talk. He says, email is an innovation. Many years later, it's still being misused, misunderstood, and how best to apply it as a tool to communicate. So telehealth will also go through an evolving process, thus changing data outcomes, including unintended consequences for all stakeholders. So again, yeah, none of these technology questions are closed questions, they're ongoing, but telehealth is going to be with us now in a way that we didn't predict 6 months ago. So that's really fascinating. But do other folks that are in the talk here want to have some questions? You could raise your hand using the participant window. You could type into the chat. We could also just open up people's microphones here. So let's just try to open it up a little bit.
While we're doing that, Thomas, I'd give a quick response. I think that Steve brought up a really important and interesting point, and this is another one that I harp on a lot, ask my executive team. The idea of email as applied to healthcare is arguably a solution looking for a problem. It is not a purpose-built tool. So we're like, well, this is a tool that helps us communicate, so how can we apply it to healthcare? Rather than really starting with the problem in mind of how do we better communicate these key issues around care, and what tool can we build that can truly solve that problem. So again, a short answer to a complex question, but hopefully for Steve, that gives at least a little bit of perspective on how we think about it.
Yeah, we might say email is a problem looking for a problem. So that's interesting. Marjorie, you've opened up a little bit. You want to bring up a point here?
Yeah, I thought this was really interesting, but I noticed that you're all clinicians. I would like to raise the question of what does it change in terms of the responsibility of the patient? Does it place on the patient new responsibilities for knowledge and understanding of both physical conditions and physiology? Does it place on the patient new responsibilities for, in fact, being able to deal with the clinician as a co-equal in a participatory discussion rather than the recipient of God-given wisdom?
I think, Marjorie, the quick answer on that is not if it's done well. So if we put that burden on our patients, that's arguably one of the challenges that comes from email as a clinical tool, is that it requires patients to have some understanding of when is that the right tool, when is it not the right tool, and well-built products don't do that. If you think about what makes Google so successful, it's pure simplicity. I don't need to know anything before I go in there. I can figure out how to be able to use it quickly and easily, and that's the beauty of Apple's products. I mean, and if you build technology that burdens the end user, then you've built bad product. So.
I agree with that, and you know, we're testing a variety of different remote patient monitoring tools right now. In other words, these are tools that the patient receives to monitor their own blood pressure, or during COVID, measure their, we sent out pulse oximeters. Forgive me, Ray, if I'm butchering that.
You got it right. Yeah, the little thing goes on your finger. Yeah.
Yeah, and it plugs into your phone to measure your oxygen levels in your blood. And then thermometers that we sent to patients to have them to be able to take their own temperatures. So yeah, I mean, there is going to be more responsibility for the patient. I won't deny it for those patients, but in exchange, the patient doesn't have to leave their home. They can talk to the provider through the phone or on video, and you know, they're not worried about if they have COVID having to go into a clinic, or if they don't have COVID having to go into a clinic and possibly being exposed, right? So, you know, having tools that, you know, meet the patient, that are simple to use, and that are integratable into the EMR for the provider side are also really important, because you don't want data being collected that isn't synchronized back to the health record system either. you want to have an integrated tool that keeps everything in one place for both patient records. So the patient has access to all their information, and so does the provider.
Yeah. Seems to me everything's going to be cobbled together. I think we're not going to be able to erase the slate. I mean, we could have movements to defund the hospitals, I suppose, too, and just start from scratch. I don't think that's going to happen. Yeah.
You're getting controversial, Thomas.
Yeah. But we're going to be cobbling things together. We're going to have, in our law enforcement talk, we talked about, we have 20th century law enforcement. The focus of the talk was that we're trying to move law enforcement and public health and the idea of policing into the 21st century. But really, we have a lot of 20th century, and in fact, we have a lot of 19th century and even 18th century ideas in law enforcement. And I think this is the same with healthcare. We've got 21st century visions, and it's overlaid on 20th century and older kind of ideas. So it is going to be
one thing. Actually, there's an analogy, Thomas, that might be helpful. I found this one to be helpful. Banking. I mean, there was a time not that long ago, I can remember going in with my dad to see a teller for every single transaction that needed to happen in banking. All of them. It was like a regular thing. I knew the tellers by name because I was going with my dad to be like, they recognized that because my dad was a gregarious guy and got to know those people, and that's lovely. But we have in the banking industry, they have built products that are easy for people to be able to use and have helped have helped banking customers easily know what tools are there to meet different needs. If I need to check my balance, I can just log into my application. If I want to deposit a check, I've got tools that make that easy for me to be able to understand. If I need to get a quote on my mortgage, there are tools that make that very easy for people to be able to do that. And the burden is on us as an industry to be able to do that same thing, to recognize the different needs that patients and healthcare consumers have and build tools that meet the needs on both sides of that equation. They have to meet the needs of the bank, understanding this information in order to give you a quote for your mortgage refinance, and also meet the banking consumers' needs of convenience and ease of use and accessibility and digitization. And it has been done in other complex regulated industries, and there are tools out there that already can do a much better job than we have at that.
Yeah, and Ray, what I would add to that though is that what banking or like AT&T talks to Verizon, what they agreed on are standards on how to talk to each other. And one of the biggest challenges we have in healthcare is we all don't agree on what standards.
The biggest cottage industry in the world. Yeah.
Everybody has their own way to build a widget, right? And so it's like, well, Washington looks at social determinants of health and the data that they have to capture differently than like Oregon or the federal government. Like that's just one example, but like thinking about technology, one of the biggest challenges we have is the lack of standards across the country in healthcare technology. I mean, we're getting better at it and we're making slow progress, but oh my gosh, it is so hard because we have all these different standards, both on a federal, a state, a local level. Look at contact tracing right now. One of the biggest challenges that we have is that every local public health jurisdiction has different requirements on how do you report data. So, we're doing everything we can to think about how do you standardize that. And we just launched this really cool thing with the CDC on electronic case reporting to try to drive a national standard to set standards around this. But this is one of the biggest obstacles we have in healthcare technology is the lack of standardization around, the tools that we implement.
Mm-hmm. That's a tough point too, and that's the people that I know that have been working in this area for a long time. They work on broadband, they work on standards because that's what it always comes down to is these basic things. And I want to bring it back to Marjorie's question a little bit about the empowering the patient. But it's the patient experience. But what about elders in general as a demographic group? And that's a broad, diverse group. We could have we could have Marjorie, who's a highly, empowered, educated, elder person in Washington, D.C. And her, the aging and style group is one kind of demographic for elders. Then we have other elders that are folks that are not, computer literate, that aren't comfortable with technology, that are arguably heavy users of healthcare. So how do we serve, those two classes of elders?
I might even take that and say that the age piece isn't the relevant segmentation there. It is the tech savviness and tech comfort and tech forwardness. And I think that is arguably better because we have low income populations that also haven't had the benefit of frequent interaction with tech. So I think it often gets sliced again by demographics. And I'm not convinced that that's actually the right way to be able to do it. It's about understanding the challenges that people face, and then again, building tools that really that meet people where they're at, rather than telling them what they should be able to do. It is like any other good industry or good product. It's about meeting people where they're at and giving them tools that make the job that they have easy to get done. So it's, we see good data. I mean, on our side, and inside of Bright.md, because we have worked hard to be able to make it so that you don't have to figure out video conferencing. It's easier than texting to be able to engage and get care. We're actually seeing some of the best utilization numbers among the over 65 Medicare age population of any remote care tool that we've seen out there, pre and during COVID. It's not about whether people are willing to use technology. This is actually, I'll flip this a little bit. I know that we weren't talking about clinicians, but healthcare has gotten a reputation for being slow to adopt technology innovations. An interesting counterpoint to that is, do you know what the first professional group to get above 90% penetrance on smartphones is? This is a long time ago. It's clinicians. Clinicians love great tech. I mean, like, as a group, I mean, again, everything is a bell curve, but clinicians love great tech. You know what they don't like? Tech that gets in their way. And building tools that meet clinicians' needs, they are more than happy to be able to do that. And the same thing goes for patients as well. So it really is. It comes down to, are we building the tools that are truly solving the problems out there that people face? Or are we building tools and then telling people that this is the way that you have to be able to get care, so do it whether it works or not? So
I would also say, to that point too, it's the tools, but it's also the implementation of the tools and training. And
oh yes, great point, Jen.
Yeah. So, I mean, we can't just identify seniors as having challenges with technology. I think that stigma needs to be knocked down very quickly.
Yes.
It is about technology literacy more than anything else. And so in our population, we're working really hard to find ways to overcome that and literally innovating on the fly around it. So one of the things that some health centers have started to do is centralize the pre-appointment. So even before a virtual appointment, spend time on the phone with the patient to ensure that their tools are downloaded. The Zoom is downloaded, that they have a tool that's easy, that's fully launched from the text. They get a text, they launch the text, and it goes right into the appointment. So trying to take a lot of that steps out by having staff that help build that into the workflow in a pre-appointment to the virtual visit, if that's the method that that provider wants to meet the patient. So again, this is all about the learning and part of the innovation. Technology is only as good as the implementation and the training and the use of the tool. And the other thing that drives providers crazy is any redundancy, anything duplicative that they need to do. And so I spend a lot of time saying, oh, we already do that. Let's not do that again, and find ways to simplify, again, using Ray's term, the process, because you know, that's part of the literacy and the frustration is I'm already doing it. Or like a patient walks in and they have to, I get crazy every time I have to go in and fill out a paper form. I'm like, it's in the EMR. I gave it to you the last time I was here. I'm not telling you anything new, and I won't fill out the form. It makes me crazy.
Yeah. Yeah, and I used to tease about this, like whoever said that there's no such thing as a stupid question has never filled out an intake form at the clinic. Like if you ask me my name the 5th time, arguably at some point that becomes a stupid question. You should know that about me. I mean, it's a very obvious example. I think you're completely right about that.
Yeah. I have this image in my mind, my late mother who passed away a couple of years ago, I would, visit her back in Buffalo, New York, where I'm from. And she's, high school educated woman and had COPD and some other chronic health issues. And we would take her to one of these remote labs to get her labs. And I thought that was sort of a good example of a really difficult and not very well designed healthcare interface. You walk into some nondescript building in a waiting room and there's no reception. There used to be a receptionist, but they're gone, and there's just a screen that you have to punch in to find your appointment. And I remember being there and just watching a number of patients come in and not being able to use that screen. They couldn't even, and one older gentleman just getting frustrated and just pounding on the screen, and it was just really sad. And I think that was a great example of the dystopian kind of danger with some of this technology stuff, is we don't think about the user experience or the outcomes. We just say this is cheap and easy, and it really is terrible. So I want to kind of think about that a little bit too, because there are some really downsides to automating things that I think will lead to really bad experiences.
Yeah,
Mm-hmm.
Agreed. Mm-hmm. Representative on those old phone trees. Yes, mm-hmm. Absolutely. Yeah.
Other questions we can move toward wrapping up, or we can keep talking. I mean, this is fascinating. We've got some other attendees. Other folks in our audience have any thoughts or questions, either on user experience or on the ethics or on the technology? Marjorie, yeah.
Am I on? Yeah. I have had some recent experience with friends here in Washington that are actually rather wonderful uses of telemedicine, mm-hmm. where they have had very complex disease problems and they needed consultations that went across the cities. So in this case, it was a difficult blood cancer, and there was both a Washington National Hospital person here and also a Sloan Kettering person. And they were using photographs of the sarcoma to exchange information and to decide on a treatment plan with the patient in the discussion. And I thought that was an extraordinary breakthrough of breaking the model of a local medicine versus national or even international medicine.
Yep. I agree with you, Marjorie. I think it brings up another interesting point, which is there are arguably two different models of remote care. We'll try and shed some of those labels of telehealth, telemedicine, virtual care. The idea of being able to do things, removing geography as a barrier to care is, let's talk about it. Let's define it as by the value that we're looking to create from those kinds of things. There are some really interesting applications of that. That's another asynchronous model. I think, again, you don't need a video encounter to be able to do that. That asynchronous component is really key. The other interesting one that you bring up there that I think is worth thinking about is your user groups are different in that setting. So that's a consultative setting where you've got two clinicians looking to be able to connect with each other. And that's a very different set of users than connecting a patient with a provider. And I've seen health systems often, they're like, well, we've got this infrastructure in place to be able to do this consultative telehealth thing. Let's use it to let patients connect with providers.
Yeah,
not great, not a great model to be able to do that. And I agree with you. It's a wonderful breakthrough, and there are incredible powers to be able to say, now it's not a local interaction. It can truly be remote, and you can connect with folks who are more experienced and specialized in the area of blood cancers or some of these more rare conditions that really you can't have one in every city. But we also need to be aware that what works in one setting will not necessarily be the right platform or tool for another use case. And we don't want to run the risk of starting with the solution and going and looking for the problems that it might be able to solve. But I think it's a great example. I think you're absolutely right, and it's helped move healthcare forward substantially.
Yeah, and what Ray's talking about are what we call e-consults, which is the provider to provider having a conversation before a referral is made. And, we have implemented e-consult for our health centers across the country. The reason that that's super important is because only about 3 out of 10 referrals to a specialist is ever completed within the safety net. I mean, it's really low. Patients get, so, you might get a referral to a dermatologist. Well, only 3 out of 10 times does that patient actually go see a dermatologist. I mean, it's stunningly bad in the safety net specifically, and for numbers of reasons, which I won't go into here. But if we can bring that specialty service to the primary care provider and have the primary care provider talk to a specialist in advance and have that care delivery in that primary care model through a consult, I mean, that is a whole nother level of telehealth that we didn't talk about or didn't focus on today, but it's something that's also happening as part of the larger conversation about redesigning healthcare. And we're really excited, and we've leaned heavily into the e-consult and again, what Ray was talking about is synchronous and asynchronous as 2 different methodologies in which to deliver telehealth. So we're really excited.
I think there's actually there's an interesting company. I don't hold any shares in them, and so no disclosures needed. But I will disclose that I have no disclosures. But we just had an interesting conversation with the CEO over there, and it's Rubicon MD, and they're looking to be able to. Again, I'm not saying that they're the right answer, but their focus is specifically on that primary care to specialty consultative model. How do we bring the specialist into the primary care setting so that it is accessible to both the clinician and we can get that care happening in the moment when we already have that patient engagement in the primary care setting, to Jen's point. So there are also, again, tools and companies out there looking to be able to have an impact specifically in that space.
Yeah, just a note. There was another Techlandia session on the future of work dependent community that's happening at 11:30 there. That has a different Zoom login, and that's in the chat if someone was planning on sequencing over to that at 11:30. But for our time, I want to move it into something even more interesting here. What about single payer or national healthcare system and how that would change the dynamics here? Do either of you, Jennifer or Ray, are you aware of just how telehealth and some of these questions are being answered in other countries like Canada or in the EU, where they have less fragmented, more national, standards? Because I think we are really, lagging behind in the United States in this area. So what would it look like if we had a single payer or a national healthcare system? How would it change the game?
Thomas, are you deliberately putting a soapbox in front of me? This is a dangerous thing here. I want to own that before even getting up there.
How often do we get a chance? I don't think anyone's gonna. I think we're all interested in these questions. So go ahead.
So we are the only developed nation in the world that doesn't have universal healthcare coverage. So leaving aside how we pay for that, I think there are multiple different models out there. Whether you look at the Bismarck model in Germany, or you're looking at the beverage model in Great Britain, or some of the blended models out there in Canada or France, or I should say variations on those Bismarck or beverage models. I think we are the only developed country in the world who hasn't embraced the idea that access to healthcare is an expectation and a right. Now, I think that is a factual statement. So leaving aside the politics of how that happens and what the right structure is for us to be able to put things in place around that, we are a clear outlier in terms of that decision that we have made as a country. The interesting thing is that because of that decision that we have made so far is we don't have one system of care. We've actually got 4 or 5. We do have, depending on which segment, if you look at the VA, it is a truly national single payer model that comes out of the federal government. If you look at the uninsured, it's arguably a self-pay model like India. If you look at our Medicare model, it really looks like Canada. We have actually in some segments embraced pretty much every model that's out there, but we haven't been decisive. The political football of healthcare has kept us from being able to commit to a model that truly does give us that universal coverage. And I would say without extrapolating more in this setting than I should, I would say the correlation between that and the fact that we are spending 2 to 3 times more on a per capita basis than any other developed country in the world on our healthcare is striking to me. And the fact that we're also ranked 38th in the world, just right around the same, I think we were just above Slovenia in terms of the WHO rankings on healthcare outcomes, which includes longevity, it includes infant and maternal mortality, it includes quality of life metrics, it includes universality of access, things that we all should care about deeply. We are 38th in the world, while by far and away being number 1 in the world on healthcare spend. And so those are all factual statements. And the question then is, what are we planning to do about it? And that's the topic that's hairy enough that I don't know whether we want to crack it open right now. But I think that we should at least start with that factual foundation for any kind of a conversation that's pointed in that direction. Jen, I know this is an area you spend a lot of time around. Any thoughts or disagreements on that?
No, I think that's spot on. What I look at is also the urban and rural discussion, right? And we're seeing rural critical access hospitals closing left and right, the lack of viability of those organizations, and COVID is not going to do them any more favors. And they're going to really struggle to survive. And what it means is that we're seeing health centers as really the last remaining primary care delivery model in those communities, picking up a lot of those patients. So health centers are seeing more complex patients for longer periods of time. We have built hospitals essentially during the COVID crisis for many of our FQHCs because of the homeless populations or other special populations that had been diagnosed with COVID with no place to go. So they needed housing, they needed healthcare, they needed hospitalization. So it's been really interesting to see as we've had this fragmented delivery system, especially the impact on rural communities, and that they're the ones really getting pinched more than the urban centers where you have multiple options for care. When you're the only game in town and that game closes, who takes those patients? What kind of distance do they have to travel? And specifically when it comes to this conversation, how do we bridge in and innovate within the virtual care models to be able to meet the growing demands and changing demands of what is an aging population in our rural settings? So these are the things that we think about a lot, more so than the national payer framework. Is we've got all these divided systems, and how do we bridge gaps, and how do we get to the next level, and how do we make sure that they're sustainable and viable long term?
Why is it that rural hospitals are closing?
You want me to take that one for a
question.
So, I mean, the quick version, they got hit much, much harder on the revenue side of things during this pandemic crisis. This is another thing that is truly unique to us as a country. This is something that folks that aren't deep in healthcare don't necessarily recognize. Why is it that during a global pandemic, where there is a tremendous amount of healthcare need, do health systems actually take a hit on revenues? And that is unique to us as a country. There is no other developed country in the world that is struggling with that economic reality. Everyone else in the world, their health systems continue to operate with a sustained budget. And we have seen particularly rural health systems have taken as much as a 70+% hit to their revenues because they've had to close their doors to care delivery, especially, in fact, on a fee-for-service basis. They've got to close their doors to the higher margin, more profitable visits that they aren't able to do with their clinics closed. Mm-hmm. And I think we have built a system that led to that specific outcome uniquely in the world.
Well, and they were closing at a rate of one hospital a month prior to
Yes. Yeah,
so,
we've accelerated it. We didn't start it. Fair point,
I mean, because
Jen. Totally
you took away all their elective procedures, which were driving revenue during COVID because they had to close their doors. And, you know, the knees and the hips of the world, those are what keep the doors open. And so they're really going to struggle. And so rural America is going to be, needing new care delivery models. I mean, these models that are out there in the hospital systems were designed in the 1950s and haven't been modernized really since. They haven't been truly thought of as what do rural communities need? What does, you know, Ontario need for care delivery? Ontario, Oregon, what do they need? What does John Day need? And, you know, what can be bridged in, what can be stabilized and then medevaced out. I mean, right now it's, you know, we have to really think about what does healthcare look like in rural communities. And we haven't done that hard work and that introspective work yet.
Yeah. And tying this back, Thomas, to your question, other countries who do have a more unified model of care have had a better foundation to be able to build on some of those specific issues because of that.
Yeah. So essentially, I mean, as a more of a layperson, the hospitals have had, because they were working on a for-profit model, they've had to subsidize their emergency and other things with the elective procedures like hip replacements and knee things and things like that, and that's how they actually make enough money to run. And when COVID says, well, we're gonna postpone all these elective things, then all the revenue goes down.
So one thing I'd subtly say there is it's not for-profit or not for-profit. The vast majority of care that is delivered, by far the majority of healthcare that is delivered in the United States is not for-profit. I mean, you point a finger at a health system and almost certainly it is a not-for-profit organization. So it is not the for-profit versus not-for-profit model. It is about fee-for-service versus value-based care. So fee-for-service health systems are, I mean, there is an argument to be made that in a fee-for-service world, you do something, submit a bill, get paid. That's the model for that. And what that arguably incents is to do more things. And whether those things are necessary or appropriate, I think, thank goodness we have an industry. Healthcare as an industry is filled with folks who genuinely want to do the right thing and make sure that patients get the care that they need and deserve. Because if we didn't have that mission-driven mindset in our industry, the misaligned incentives that we have would be devastating. Maybe in some ways it's not good because it's let it sustain for as long as it has, but it certainly has kept those misaligned incentives from being there. Hospitals get paid for doing more things, for filling hospital beds and imaging suites and cath labs and ambulatory surgery centers. That is what a fee-for-service model incents and delivers. If you look at a more value-based care model, what do patients really want from healthcare? Patients don't want to see their doctor. They want to not have to see their doctor. That is really the aligned outcome that I think all of us would like to be able to see. When I need to see my doctor, I want that to be efficient and delightful and accessible and affordable. But what I want even more than that is to not have to. And as a doc, I think I can say that with a straight face. Nobody wants to come see the doctor, not really. And so, and those value-based care type models, though, that's the distinction. So,
and Thomas,
make sense?
It brings it back to the very beginning of what I was talking about is because health centers have just been able to start using telehealth in any sort of capacity, underserved communities and rural communities and others that are outside of the big systems, right? We need more time to really understand innovation that's right for especially integrated primary care delivery models. We just haven't had this as a tool to be able to incorporate, to understand what it means. But it has vastly accelerated the conversation of moving from a fee-for-service model, a pay as you go and you get paid for service, to let's bundle the payment. Let's think about you're delivering care for that patient. You're responsible for that patient in a value-based model. And so we need time to really understand that. And so some certainty around payment is really important, back to why the governor drove the agenda item with the payers. We need time. We need some time to innovate. I would argue that we need more time than December, but we definitely need more time.
Great. Yeah, so our talk is about the revolution in telehealth, and I think we've really kind of opened up this area in a lot of levels here. It's not that simple. You know, we could have great technology, but doesn't mean anyone will use it. Someone has to pay for it. We have this, so that leads us to the payer system. That doesn't mean someone can access it because they don't have broadband. So I do think there are places for people to plug in on this, you know, in terms of advocacy. You know, what we have, a groundswell that's coming out of this particular Techlandia meeting based on our first talk on design, is this idea of design and what we call liberatory design, like really what the design that's really based in justice. And so I think I could see, you know, you both, Ray and Jennifer, being a part of this larger conversation about design. Like, how do we design things that work better, that are just, you know, that do bring in the needs of people, you know, as the stakeholders really at the ground, you know, at the first step, bringing in, you know, because I do, you know, at the risk of being too profound, I do think, you know, we're in a place in our country where it's not just defunding police, it's defunding hospitals, defunding the country. We're at a shift here, a 21st century shift. A lot of old systems are really fraying, and there's this tipping point of something happening here. And I think healthcare is just one example of that. It was pretty fascinating times.
You're talking about infrastructure, right? I mean, we're having the larger conversation of infrastructure. I mean, our roads haven't been rebuilt. Our bridges haven't been rebuilt. I mean, we need to rebuild our infrastructure, and our healthcare delivery systems is an infrastructure that, if you put that frame on it, really needs to be rethought of and rebuilt.
Yeah.
And not just the bricks and mortar of it, but how we do it. Is that what you're saying, Jen?
Yeah, totally.
Yeah, it's the human factors. It's how, you know, who benefits, who doesn't, who makes the decisions, all of these kinds of things, you know. Yeah, I mean, medicine and healthcare has been a very top-down, you know, patriarchal model where certain people are making decisions and the public's meant to go along with that. And I think that's clearly run its, that generation of services has run its course in some way. So it's fascinating. Well, I'm going to wrap us up for today. There's this, you know, this is being recorded, and so we're going to have a record of this, and, you know, I think we can get this out to other people who are interested in this topic. So I really want to thank Jennifer and Ray for your time and your expertise today, and for all our attendees, and Tech Association for helping put this on. I would like to do more design talks, so hopefully, you know, we'll be in touch some more. We could do a whole week on just telehealth and medicine and healthcare, obviously. So I want to thank you. Any last words from our presenters before we close?
No, we're at a tipping point. I think that's the key thing that I'd like to leave everybody with. And we have the opportunity to tip forward or tip backwards. And so encouraging everybody to kind of really lean in and tip forward, especially around virtual care. and think about, how just a larger transformation that this could be delivered to our healthcare delivery system, which could be the key thing that we've needed all along.
And the benefit of going second, Jen, I agree with you. I would characterize it slightly differently in that we're at a crucible moment. We have an opportunity to reshape. There's an old adage that my dad used to say. He said, there's 3 frogs sitting on a log. One of them decides to jump into the water. How many frogs are on the log? 3. Deciding is not action. And in order for us to take advantage of that crucible moment, it's not just about saying and recognizing that it is an opportunity. It is, to your point, Jen, leaning in. It is taking action. It is pushing for the change to help our legislation and our regulatory environment support the better options that are already out there and available, but have those regulatory barriers that are keeping us from being able to get the value out of them that we should.
All right, so I think everyone in our talk is going to be much more aware of some things here and aware of some of the bigger systems. So thank you very much. Thanks again to TAO, and I think we're going to close off, and then the TAO, I think it might still be Riley, will kind of close off our Zoom, this Zoom chat. So take care of yourselves. And be well and be safe.
Thank you, Thomas. Thank you, Jen. Good to talk with you both.
Thank you, Thomas. Thanks, Ray. See ya.
Bye-bye.